What's going on, guys? So today we are going to do things a little bit differently. Instead of doing just kind of a walkthrough lecture, going through all the different medications and whatnot of a certain disease state, we're going to do a patient case. So I haven't done too many of these before, but we're going to hopefully this will be helpful and we might maybe start doing more of them. So we're going to talk about primary hypertension treatment, and we're going to go through. This is a patient that I actually saw in clinic. And so hopefully this will help kind of put that American Heart Association guidelines and their algorithm sort of in perspective of an actual patient and how you can kind of utilize this. But we'll see how it goes. So the patient is a 55-year-old male with a past medical history of diabetes type 2, hypertension, and CKD stage 2, as well as dyslipidemia. Some of the pertinent information that we have, baseline blood pressure today was 190/88. That is definitely higher than we like. An estimated GFR of 63 mils per minute, a hemoglobin A1C of 8.8, and an albumin creatinine ratio of 710. Medication list is Lisinopril 20 milligrams a day, which actually he was not taking. I found that out after I started the appointment with him. Amlodipine 10 milligrams, metformin ER 500 milligrams two times a day, and Jardiance 25 milligrams once daily, atorvastatin 80 milligrams daily. Now, the referral that came to me from this primary care physician basically was saying or suggesting, what do I think about lisinopril HCTZ as a combo, since he was only taking one medication to begin with and not taking his amlodipine and lisinopril. What do I think about the lisinopril HCTZ combo? Would that be a good option? That way we can kind of improve adherence and all that. So always want to simplify regimens if possible. Definitely want to try to promote any method we can to increase adherence and things like that. However, I will say, we have this tendency to think about blood pressure is just a number, and whatever we can do to get that number down, great. The blood pressure is down, then we kind of correlate that with, positive outcomes in the future. However, that doesn't always play out that way, and it's kind of important, from a mechanism standpoint, how we actually lower the blood pressure just as much as it is, the fact that we are in fact lowering it. So the landmark trial, if you will, that really kind of, I think, lays this out nicely is the Accomplish trial, which was from 2008 in the New England Journal of Medicine, and it compared benazepril plus amlodipine versus benazepril plus hydrochlorothiazide in patients that had hypertension. They were considered high risk, so they had kind of a mixture of comorbidities, diabetes, things like that. But the interesting thing about at the end of the study, which was actually stopped early for significance, so we'll get to that in a second, but the study was stopped a couple years early, and the first thing you kind of jumps out at you is when you look at the blood pressure results. At the end of the study, the group that had the benazepril and amlodipine was 131.6 systolic over 73.3 versus an average of 132.5 over 74.4. So almost identical blood pressure lowering. So I would say, according to a lot of people, that's kind of perfect. Let's use either one of them. Whatever we can get the patient on is going to be great. However, the primary composite, which made up of some cardiovascular events and then death from cardiovascular causes, was statistically significant in favor of benazepril amlodipine. So there was an absolute risk reduction of 2.2% and a number needed to treat of 45. Now, that being said, it was driven primarily by non-fatal MI as well as revascularization or incidence of revascularization procedures. When you separated out the individual endpoints, you didn't really see the change in all-cause mortality or cardiovascular death or things like that. Stroke wasn't a big difference. But still, regardless, we got better outcomes, and I suspect if we had let the study go to its full term that we may have started to see those other ones because they were all moving towards significance. So we may have seen significant outcomes if we had let the study run its course. But the point is, again, it's not so much that we're just lowering the blood pressure. Of course, that's important. But mechanistically, how are we actually lowering the blood pressure is also an important factor. And, my thought here is that, okay, the patient is, getting amlodipine already. I would rather just add the ACE inhibitor or an ARB, if you want to go that route, back instead of swapping out the amlodipine altogether and using an ACE plus HTTZ. You'll see when we get to the thiazide and thiazide-likes, I'm really not a fan of HTTZ anyway. If you've listened to my podcast or anything, you definitely have heard that before. But it's something that, I like the combo of the ACE or ARB plus amlodipine in this patient. He's got diabetes. Plus, in this case, we really do want an ACE inhibitor because he's basically got proteinuria. His albumin creatinine ratio would be stage 3. And so, these kidney disease as well could be progressing. So, there's a lot of factors that would push us towards adding that ACE inhibitor back on. So, the couple things to kind of consider, clinically speaking, as of right now, with what he's taking, the amlodipine by itself, are there any issues with the patient taking amlodipine as monotherapy besides the fact that his blood pressure is terrible? That's obvious, but other than that, like, was there any concerns? And the other question is, if this patient was complaining of peripheral edema while using amlodipine as monotherapy, then would we give them a loop diuretic to diurese them, or how would we handle that besides just stopping the medication altogether? So those are our two questions. The first one we'll answer by looking at this kind of rough picture. It's very, very simplistic, but when we give a dihydropyridine calcium channel blocker like amlodipine, it is going to dilate the afferent arteriole of the nephron. So you are going to basically open up that arteriole, allow more blood flow into the glomerulus, which, because there's nothing on the efferent side to dilate that, you have this potential for increased intraglomerular pressure, and you can actually worsen over time the risk or occurrence, if they've already have it, of proteinuria. So the amlodipine by itself is actually probably making that proteinuria worse because you're not getting that dilation on the efferent side of things. So the ACE inhibitor, the ARBs, those are going to help to open up the efferent side and allow that interglomerular pressure to decrease. And so you actually, that's one of the ways that they're renal protective to begin with. But especially when you give a calcium channel blocker to a patient who's already got proteinuria like this patient does, we definitely want to make sure we have that RAS inhibition on board to make sure that we're not worsening his proteinuria. If for whatever reason an ACE or ARB was not an option, we still needed to worry about this renal protection. In this case, because the T-type calcium channel blockers can be on both the afferent and the efferent side of things, the something like diltiazem or verapamil, usually people go with diltiazem, so the non-dihydropyridine calcium channel blockers, are potentially an option here to dilate both the afferent and the efferent side. So don't see them a lot in just standard primary hypertension, but in this case, if you had to protect the kidneys and reduce that risk of proteinuria, that would be another option if the ACE or ARB was not. So that's the one big thing about another kind of point for adding back the ACE inhibitor as opposed to a thiazide at this point. So question number 2 was the peripheral edema. We've all heard patients complain of peripheral edema from a calcium channel blocker, but is that a fluid retention problem like we would see typically with like pitting edema? So what's actually happening here is the amlodipine and the calcium channel blocker is dilating the precapillary bed. So they're dilating the arterial side of things, and so blood flow is going into the capillaries. The intracapillary pressure increases, which causes the capillaries to swell, and because there's no ACE or ARB on the board, you are not getting the dilation of the postcapillary bed, the venous side, and so you end up having this edema, but it's from a capillary swelling problem, not a fluid retention problem. So giving a loop diuretic here actually really won't do much. And in fact, there's been several articles that kind of review this mechanism, this pharmacology involved with this, to encourage clinicians not to use a loop diuretic for amlodipine caused peripheral edema. Now, the ACE or ARB is going to dilate the postcapillary bed, decrease that intracapillary pressure, and hopefully things will get back to normal. The edema goes away. So, again, there's some other strategies we could do if we needed to, but that's the main one. So hopefully just getting him back on the ACE or ARB will take care of that issue. All right, the other thing we can consider, and especially kind of moving forward, if his blood pressure is not controlled, which I suspect it wouldn't be, even at this visit, even though obviously I'm cheating because I know the end of this case, but at this point, I'm still suspecting it's probably not going to be enough just because his systolic is so high, and there's a few different strategies that we can go with as far as optimizing the dose of the lisinopril, or the timing of the lisinopril dose as well. And so if the patient is just very reluctant to do anything other than, the one tablet of the lisinopril, because the main strategy I try to go with is actually separating the dose out. So instead of going up to 40 milligrams, I try to do 20 milligrams twice a day. And the half-life of lisinopril is roughly about 12 hours. So dosing it twice a day actually is, kinetically speaking, better, and as well as outcome as well. We've seen that in a study from 2017. And so splitting the dose to 20 milligrams instead of 40 once a day, we're splitting it to 20 milligrams twice a day. That gives us a little bit better blood pressure control. Now, if the patient's unwilling to do that, they don't want to have to take lisinopril twice. Now, if you can convince them maybe to at least take the amlodipine in the morning and the lisinopril at night, you still may get a little bit more benefit there, just because the RAS system tends to be more physiologically active at night. Plus, you have the whole kind of debate around if someone's a dipper versus a non-dipper. In other words, if their blood pressure goes down at night, like kind of following a normal circadian rhythm, or is it going to kind of go up at night, or especially in the early morning, a non-dipper? Unless you're doing like 24-hour ambulatory blood pressure monitoring, you may not know what the patient's rhythm and natural stasis is. So if you don't, the ACE inhibitor at night kind of covers that fresh dose if they happen to be a non-dipper, and also if the RAS system is more active. The amlodipine comes on in the morning, and so if they are a dipper, like what we used to think is normal, then you're also getting a fresh dose of amlodipine in the morning and kind of going from there. But again, ideally, we would try to split the dose of the lisinopril and maximize that blood pressure lowering benefit there. So those are two different strategies that you could utilize. If you guys hear thunder and stuff in the background, it's because it's like storming really bad. So I apologize if it's distracting. So this is a study I mentioned from 2017 that basically looked at the efficacy and safety of twice versus once daily dosing of lisinopril, and they found that the twice daily dosing gave a 10.2 over 4.3 average millimeters per mercury greater reduction in blood pressure lowering. So twice daily definitely was the way to go. All right, appointment number 2. So at this point, came back for a second appointment. It was 180 over 80 was his blood pressure. So now what? Because obviously that did not work as well as we had hoped. We have to do something else because that's 180 is not an ideal systolic blood pressure. So the next option, according to the guidelines as well, is going to be adding a thiazide or thiazide-like, because you want to utilize ACE or ARB, calcium channel blocker, and then thiazide-like, in whichever order pertains to that specific patient based on comorbidities and all that good stuff. But you want to use those 3 agents unless there's a contraindication to one of them before you move on to some of the more more miscellaneous, if you will, classes. So he is a candidate for thiazide and or thiazide-like. So the big debate is going to be, okay, HCTZ, chlorthalidone, or indapamide. And most of the time, you will see patients get put on HCTZ. It's very, very commonly used. It's one that has, multiple combo products available, all that good stuff. So, it's one of those things that just because something's done a lot, it's done by the majority of clinicians even, doesn't mean it's always right. So kind of keep that in mind. The one issue we have with HCTZ, and a lot of people that kind of follow evidence-based medicine have with HCTZ, I shouldn't say one, the big reason is that it doesn't really have any good outcome data. We have data showing that it lowers blood pressure, and we have like meta-analyses and things like that, but HCTZ doesn't have solid outcome data. And we already mentioned it's not just enough to lower the blood pressure, here and now. We want to keep the patient safe going forward long term. So it's important to know how we lower the blood pressure, and then also too, is there data to support long-term use, which we don't have with HCTZ. However, with chlorthalidone, we have multiple studies that have showed actual, not just blood pressure lowering, but actual outcome data as well. So things like the chlorthalidone in the ALHAT trial. ALHAT's a very big study that was done. It's compared lisinopril and amlodipine to chlorthalidone for like first-line monotherapy. People are very familiar with that, but it did show that it decreased cardiovascular mortality. The SHEP trial also used chlorthalidone and showed that it was beneficial there as far as outcomes go. Indapamide also has been shown to decrease cardiovascular mortality. One of the big ones that I think about is the HIVET trial, which was done in patients that were like 80 to 100 years old, and basically they were free living veterans that were given indapamide, and over a short period of time, a few years, they were seen to have decreased mortality. And then the PROGRESS trial was perindopril and indapamide. And when these were patients who had already had an ischemic stroke, and they were basically being treated with an ACE inhibitor or an ACE inhibitor plus indapamide, and the ACE inhibitor they used in that study was perindopril, but the ACE plus the indapamide was actually the one that showed the reduction in secondary stroke risk versus the ACE inhibitor by itself. So multiple studies there. There's been others as well. But HCTZ doesn't really necessarily decrease the patient's negative outcomes. And then if we want to look at it just from a blood pressure lowering standpoint, there's several different meta-analyses that have done this. One that comes to mind, shows that you get basically indapamide versus HCTZ, you get another 8 millimeters of mercury systolic reduction, and then 5 with chlorthalidone versus HCTZ. So, it's depending on, how much room you have to go, that can be a big difference when you're talking about a patient who has some significant blood pressure issues going on. So we tend to think about these medications as kind of being in the same class, but if you look at the half-life, these are very different half-lives. Really, HCTZ should probably be dosed twice a day, based on the half-life, kind of like lisinopril or some of the ARBs and other ACEs. And so, indapamide, chlorthalidone, those do tend to be true once-a-day medications. The duration of action also lasts greater than 24 hours for the chlorthalidone and indapamide. And they definitely seem to have better results overall as far as the actual blood pressure lowering. The other thing that's important is obviously there's a lot of risk with electrolyte imbalances and changes when you're on a thiazide or any kind of diuretic. And if we look at the potassium, the big argument I hear against chlorthalidone is the hypokalemia risk, which is very real. And in the SHEP trial, I will mention that if the patients had a decrease in their potassium that went that basically hypokalemia, so if it went below 3.5, patients lost all that mortality benefit that they had gained from being on chlorthalidone in the first place. So that hypokalemia risk is definitely something we need to consider, and is a reasonable argument to not use chlorthalidone, in my opinion. But if we look at indapamide, that actually has the least amount of potassium wasting out of all of these agents. So that's 1 point for indapamide as far as I'm concerned. The glucose tends to be neutral. The glucose reabsorption rather tends to be neutral versus the glucose reabsorption from the other two are increased. The renal function we'll get to in a second because we actually have data there comparing them head to head from HCTZ and indapamide. The only electrolyte imbalance that or serum change that I'm a little bit worried about with indapamide more so than the others is the uric acid. That you will get more uric acid reabsorption with indapamide versus the others. So if a patient has like uncontrolled gout, they're not on a xanthine oxidase inhibitor or something else that can help control their uric acid levels, then that's where we got to be careful with indapamide. But other than that, though, it seems to have a much cleaner profile all around. It's cheap. It's like on the $4 list at Walmart, so it's not like it's super expensive compared to these other ones. And this patient has CKD already. It's not end stage or anything like that, but we want to keep his kidneys as healthy as possible for as long as possible. And so we actually have data here showing, it's from the American Journal of Nephrology, and it compared indapamide versus HCTZ, and patients basically with on the HCTZ had a further decrease of their eGFR over time, which kind of what we expect. However, what was weird is the indapamide, their eGFR actually increased from baseline. So they got like an improvement in their kidney function. So I wouldn't say that we can definitively say there's like renal protection necessarily, but maybe. I'm kind of taking some liberties there of saying that, but indapamide does seem to have a better profile on the renal function all around. The other thing is just to mention the patient is on Jardiance. So is there any concern with the patient being on an SGLT2 inhibitor and a thiazide or thiazide-like? Most people I think would say no, maybe, but something I've been thinking about a lot is in most patients, even in patients with diabetes, when we consider patients that reabsorption of glucose, from the nephron with a thiazide or thiazide-like, it doesn't tend to be that clinically relevant to where it's something we worry about. However, if you are lowering the reuptake reabsorption threshold with the Jardiance in the proximal convoluted tubule, which means you're pushing that much more glucose into the loop of Henle and to the distal convoluted tubule to be excreted in the urine, are we getting an actual clinically relevant reuptake of glucose at that point? Because now you have a lot more glucose for the thiazide or thiazide-like to bring in, back into the system from the distal convoluted tubule, because we push that much more glucose from the SGLT2 inhibitor, and then that would also negate the whole, or at least some of the benefits of said SGLT2 inhibitor. So again, we don't know how clinically relevant that is. I haven't personally, maybe if there are, please leave it in the comments and let me know. I haven't seen any studies that show, whether or not this is truly effective or detrimental to the patient's glucose control or not. And so for me, I kind of look at it as like, well, I know indapamide's got a more neutral effect, so that's got to be a healthier, better option for the patient all around if we know we're not getting that glucose absorption or reabsorption. So I tend to go with that as well, just as another kind of bonus point for indapamide, if you will. All right, so appointment 3. The patient is now at 164/81 after starting indapamide. So let's say at this point, just for speed's sake, we've titrated doses. They're at max dose. We've done all the optimal twice daily lisinopril, all that good stuff. So now we are in the realm of resistant hypertension, and we are looking at a legit fourth line agent. What would be the best option to add? We have things like beta blockers, alpha blockers, alpha 2 agonists. We have aldosterone antagonists, things like hydralazines or some of the vasodilators. Lots of different options to choose from, but the guidelines are pretty specific as far as, which one they want you to kind of go with unless there's a contraindication. So there was a study done called Pathway 2, which compared spironolactone versus placebo, bisoprolol, and doxazosin. And they were basically looking for that optimal treatment for drug-resistant hypertension. So again, Pathway 2, and basically end of the story, spironolactone won. It had the better blood pressure control, less adverse effects, and overall just kind of a better option. Now, you have to make sure the potassium is less than or 5 or less. You have to make sure that the renal function can support spironolactone. With male patients, you do have to be careful about the dose, because if you start going above like that 25 to 50 milligram range, and with male patients, you increase the risk of them developing gynecomastia. So, there's lots of things that could potentially go wrong with it that you just want to at least be aware of and monitor. So not something that would keep you from using it in male, especially at 25 milligrams of a reasonable dose, and it can be very effective, but just kind of keep those in mind. You can also use a Plerinone, and that would cut down on the gynecomastia risk. So, let's say we are now just in this, again, in this particular case, this is really what happened, but you might be thinking like this is adding a lot of medications, and this is him meeting with a dietitian and all that good stuff too. So we were doing a lot of lifestyle management. So I don't want you to think we're doing bad medicine or something. But the blood pressure at the 4th visit was 150/76, verified with the pharmacy that he was filling at that he was in fact getting his medications. They were saying everything was adherent, blah, blah, blah. So at this point, the question was, okay, now what? Because he's already on 4 different medications. What are we going to do now? So at this point, the American Heart Association, the American College of Cardiology, those 2017 guidelines that they came up with give some guidance here, and they say that in some patients you can utilize a beta blocker at this point. Now, they are assuming at this point it's still primary hypertension, because if you have reduced ejection fraction heart failure, if you have stable ischemic heart disease, they've had an MI in the past couple of years, things like that, we would move beta blockers up the ladder as far as importance. But for just plain primary hypertension, they do not recommend this as an option unless the patient can't take spironolactone, has some kind of contraindication, and you need to try something different. But they want you to save this kind of like 5th line. And the reason why we don't use beta blockers, further up the algorithm is if we think about it very, very simply with the blood pressure equaling cardiac output times systemic vascular resistance. And then cardiac output is made up, of course, of heart rate times stroke volume. The guidelines will say that they only recommend three specific quote-unquote beta blockers, which is labetalol and carvedilol, and those are technically alpha beta blockers. And then they say nebivolol, which is a beta blocker, but it also has like nitric oxide producing properties, so you get some vasodilation in there as well. And that's the one I actually prefer for patients that have metabolic syndrome, just based on some of the metabolic profiles that you see with this. The traditional beta blockers tend to have a sort of an acute reduction in blood pressure. However, over time, you start to lose some of those benefits. So if you think about it, you have heart rate times stroke volume for is what equals the cardiac output. So you're going to initially get a decrease in cardiac output, which is going to cause a decrease in blood pressure. However, over time, that norepinephrine still needs to bind to something. And so if it starts binding to alpha receptors in the periphery, now you're going to get vasoconstriction because you have unopposed alpha activity. You're going to get vasoconstriction in the periphery, which is going to cause SVR to go up. So now you have cardiac output going down times SVR, which is now increased, and it has the potential to cause a wash in the blood pressure lowering effects. And that's the concern with beta blockers, is that we're going to lose that effectiveness. So there's other issues as well, as far as the risk of losing glucose control and weight gain and things like that with some of the more traditional beta blockers. But what they refer to as vasodilating beta blockers, like the alpha betas, labetalol, carvedilol, those are going to block the beta receptors in the heart as well as the alpha receptors in the periphery. So you're going to get a decrease in both cardiac output and SVR, and hopefully their blood pressure actually continues to move in the right direction. So if you are going to use a beta blocker in this patient population just for primary hypertension, those should be your three go-tos that you utilize. Now, I want to mention, just for the completion's sake, everyone seems to like to put patients on, I shouldn't say everyone, a lot of clinicians do seem to like the drug atenolol for hypertension management. Again, you get initial blood pressure lowering. However, remember, we're not just looking at blood pressure lowering, we're looking at outcomes. And what we see with atenolol, based on some data from the LANCET in 2004, which was a meta-analysis basically looking at atenolol versus placebo and atenolol versus other antihypertensive medications, what they found is that atenolol versus placebo basically had zero benefit. It had no difference all-cause mortality, no difference in cardiovascular mortality, MI, stroke, nothing. And when you compared it to other antihypertensives, you actually got a decrease or an increased risk of all-cause mortality, cardiovascular mortality, and MI when you compared it. So atenolol actually had a number needed to harm of 111 for the all-cause mortality and 143 with cardiovascular mortality, and which those are pretty decent-sized numbers as far as number needed to treat or harm. But in this case, if you think countrywide, how many people are on atenolol for hypertension, and you think, okay, well, out of 111 of those patients getting atenolol that probably shouldn't be, then one of those patients is going to die when they didn't need to. That's it may seem like not great odds, but I would not want to be, personally anyway, the one person that does happen to, or I wouldn't want my grandparents to be the one person that happens to. So it's just, there's such better options. I don't know why we have this infatuation with atenolol, but we don't like atenolol. And so the moral of the story is atenolol is trash. You've probably heard me say on the podcast. My students have all heard me say that. I can't stand it. It drives me nuts. And now, look, I'm going to show my support by rocking this T-shirt here. Those are available on www.coreconsultrx.com. There you go. But just kidding. Don't buy a T-shirt unless you really, really want one. But the miscellaneous agents are kind of the last hurrah, if you will. And this is where the guidelines tend to be a little bit more vague, because there's not really any great data for any of these agents. So I'll start off with doxazosin, a traditional alpha blocker, because that tends to be the one that people put on their patients more. If you remember, we talked about ALHAT in the beginning, where they covered clothalidone versus lisinopril versus amlodipine. there was actually a fourth arm of that study. It was doxazosine, and that study or that arm rather, was actually stopped early because the doxazosine patients had an increased risk of cardiovascular events and actually a 50% increase in incidence of heart failure. One potential mechanism there that's been kind of theorized is similar to the beta blocker issue, where if you're blocking beta receptors, now you have unopposed alpha activity. If you block alpha receptors, well, now you have unopposed beta activity in the heart. That's going to cause heart rate to go up. When norepinephrine is binding, it's going to cause the oxygen demand to go up, which is going to cause ventricular hypertrophy, and that can lead to obviously heart failure. So doxazosine, definitely not a good option and not really safe for hypertension, or no outcome data that's really impressive to speak of. And sometimes you'll see patients that get put on doxazosine because they have hypertension and BPH, and that's kind of like a kill two birds with one stone sort of strategy. However, the American Urologic Society actually came out and said, stop doing this. Treat them as two separate diseases. We have uroselective alpha blockers like tamsulosin. Utilize what the patient's, it's better for the patient on the BPH side, and then do evidence-based medicine for hypertension treatment. Don't just give them something because you're trying to make it easy. Of course, we want to increase adherence, but we also want the patient to have positive outcomes, because that's the most important thing. If you have great adherence and something happens to them, what did we really accomplish? So doxazosine, again, not a huge fan. I kind of leave that one off if possible. And then we also have our alpha-2 agonists, so our centrally acting agonists like clonidine. Those are generally reserved for like last line because they have CNS adverse effects, especially in older adults who may be more likely to have this type of situation of resistant hypertension. Not great options. There's even been studies that show that it's maybe not even that good of an option in like in a clinic setting where a patient comes in with high blood pressure and we're just like acutely giving them something to bring it down. They've showed that like amlodipine can actually be maybe even a better option because of the really long half-life. Now, direct vasodilators, also one that the guidelines are kind of like saved last line if you have to use them, because they're going to have issues with sodium and water retention, which obviously can increase the risk of heart failure and things as well. They're going to have an increased risk of reflex tachycardia as a result, and so that's not ideal either, especially if the patient comes off of them. So you just got to pick your poison there if you really do need these. Most patients are not going to get to this point, and the other piece of the puzzle, if they haven't done this already, hopefully by this point they have. But if you're thinking about like adding like a sixth line agent, have them meet with a dietitian to go over everything they're eating with a very fine tooth comb, because there may be something small that has a ton of sodium that they're just not aware of, and they're telling you they're eating healthy, and you find out when they say that they're eating healthy, a sandwich for lunch or something, and there's not really any salt on it. You find out they're actually getting it from Subway, and there's 1,800 milligrams of sodium. So there's things that can happen that patients just aren't thinking of or aren't aware of, and getting them in with a dietitian can be very helpful. Referring them to someone who can walk them through some exercise routines, whether it's aerobic or resistance, whatever. But a dietitian is definitely key if you are getting to the point where you're starting to talk like six line meds. Hopefully you're giving them a dietitian referral regardless, just because they have hypertension, and you can kind of get that taken care of early on so that you don't have to keep adding on meds, but it's not always the case. So keep that in mind though. Don't forget our dietitian colleagues. And by appointment number 5, after being on the Lisinopril twice a day, amlodipine, Indapamide, Spironolactone, and then a low dose of carvedilol, as well as meeting with me and the dietitian together multiple times, patient came in for his appointment number 5 at a blood pressure of 124/76. So we officially fixed him, at least for the time being. We're going to keep a close eye on him and make sure he doesn't start to creep back up again. But yes, he was very, very excited. So this is, like I said, as a patient we saw in clinic. I hope that kind of helps to lay out the how we can utilize the algorithm that the American Heart Association put out in 2017. And let me know if you have any questions. I'd love to hear your comments or thoughts in the in the comments below, and let me know if you disagree with any of my recommendations, or if you've done something different. I'd like to hear that too. I want to learn from the channel just as much as I hope you guys can get something out of it. But yeah, shoot me an email if you guys have any questions, or reach me on any of the social media platforms. Subscribe to the channel if you're not already. That helps me out as well. And I'll see you guys in the next one. And have a great night.